I'd like to thank you for being here today, and also I'd like to thank and acknowledge my colleagues for being with us. And I'd also like to thank DJO Global for sponsoring this event. I'm so lucky to work at two beautiful facilities. One of them is at Rush University in Chicago, Illinois, where I actually work in the section of rheumatology in the Department of Internal Medicine, where we do government-sponsored research on medial knee osteoarthritis. The other place I work is where I have my clinic, and that is at St. Luke's Hospital in Cedar Rapids, Iowa, where I'm working in the Department of Physical Medicine and Rehab. And there we have a makerspace where we can pretty much fabricate any kind of bracing and support feature that we want. We can add to existing bracing support features, and in addition to doing shoe modifications. So not many people can say this, but every day I go to work, I am so happy and so excited to be there. You know, every day there are about 25,000 people that sprain their ankles in the United States. If it's bad enough, they will go to the emergency room, where most clinicians don't really consider this a major problem compared to the other things they see that day. The patients may be told to take an over-the-counter non-steroidal anti-inflammatory, ice it. They provide compression with an ACE wrap, and if it's bad enough, they'll be given crutches and told to rest for a while. Usually they'll get rescheduled to see their primary care physician in a week or two and follow up with them. Unfortunately, patients with this type of treatment are left not really knowing how this future is going to turn out for them. There's always a chance that it will heal without complications. However, more than likely, these patients are going to see longer healing times as the ligaments continue to be stressed while trying to heal. You're going to see continued pain with weight bearing and ambulation. They're going to probably have more instability in that joint, as that joint is less stable, more mobile due to the injury. A lot of this is due to decreased proprioception, as we know that there are afferent nerve fibers in the joint capsule ligaments that provide a feedback mechanism that can get damaged. And these patients are prone to repeating the injury again and again due to the above things that we just mentioned, in addition to the decreased neuromuscular adaptation that happens at the lower extremity kinetic chain. So, how can we have better outcomes? Well, we can use our knowledge to try to understand the pathophysiology and biomechanics of ankle joint injury in an attempt to reduce complications and speed recovery for our patients. So I'm really not going to get into the anatomy of the ankle joint, but suffice it to say that there are many ligaments there, any of which can be damaged. But the worst case scenario is when the tib-fib syndesmosis is damaged, often called a high ankle sprain. This is going to create increased instability and pain, mostly due to the fact that the tib-fib syndesmosis maintains the integrity of that joint. It resists axial, rotational, and translational forces that occur normally during ambulation. So an ACE wrap alone is not going to maintain tib-fib integrity. You're going to need more medial lateral compressive forces coupled with the coronal plane stabilizers that we're familiar with. So if you look at artist drawings, like if you were to Google talus on the internet, you'll come up with a lot of renditions from artists on what they think a talus looks like. And they don't always show the true anatomical shape of the trochlear surface of the talus. To get this, you really need to look at a real bone. The anterior trochlear surface of the talus is actually wider than the posterior surface, which means as the ankle joint dorsiflexes, the tib-fib is going to actually separate. So in normal gait, the syndesmosis actually widens about 1 millimeter as the ankle joint goes through around 10 degrees of ankle joint dorsiflexion during gait. However, if you get excessive dorsiflexion, as you often see with ankle joint injury, you're going to force even more widening of the tibia-fibula syndesmosis, and you're going to force a disruption in those ligaments. You also have to consider that it's a closed kinetic chain situation, that the foot is planted or fixated on the ground, and so you have to look at the entire kinetic chain and what's happening both proximal and distal to the segment. So in order for the knee to extend at heel strike, the medial aspect of the tibial plafond has to go down and around the medial trochanter, or sorry, the medial condyle of the femur. Again, this occurs right at heel strike. The knee never fully gets into full extension, but always is slightly less, around 10 degrees from full extension. So for that knee to begin flexion, the tibia has to go down and around that inferiorly positioned medial femoral condyle, which means that the tibia has to travel further and faster medially than it does laterally so they can clear that inferior condyle, which also is a better way of describing what internal rotation is. So for the tibia to internally rotate in closed kinetic chain, the foot has to pronate. This is called the screw-home mechanism. It's invoked in the last 10 degrees of knee extension and is a locking mechanism. This locking mechanism is similar to how birds stand with their knees backwards. They do this in order to have the loads go through the osseous structures and not through the muscles. So if you want to prove this to yourself, all you have to do is stand up and slightly flex your knee more than 10 degrees. And what will happen is the muscles will contract to try to hold that position of that joint. Well, they can do it for a short period of time, but not for very long. Before long, your muscles will start contracting and going into spasm, and your knees will start shaking considerably. So again, this is all based on the anatomical structures and the shapes of the joints and the closed kinetic chain. So we need to consider the position of the proximal joint segments in the kinetic chain, and as well as the location of the proximal load and the ground reaction force vector. This will determine what structures are going to take the greatest force. As a subtalar joint pronates in this configuration and the tibia internally rotates when the knee is 10 degrees or less from full extension, as we see with the locking mechanism, screw-home mechanism, and with the maximum load usually occurring above the knee, you're going to see an ACL injury. However, if the knees in past 10 degrees of flexion are unlocked with a load below the knee, you will more than likely see ankle joint injury. So, knowing this, Jim Richards at University of Central Lancashire tested various ankle supports in order to get a better understanding of design configurations. So he took several different knee braces and tested them with different motions. One of them was a cutting motion, as you see in the anatomical diagram here, and the other one was a hopping motion. And again, both of these were looking at different configurations of the proximal and distal joint segments by invoking the hopping or cutting motion. And you took several different ankle braces. Some of them were just medial lateral paddles that were just Velcro together, and other ones were quite a bit more substantial, which we'll discuss later. The results were interesting. While braces did well at reducing motion in the sagittal and coronal planes, they did their best at transverse plane, in this case in the cutting configuration. In the hopping, they even did better, showing a 25% reduction of motion in the transverse plane. So it seems that braces work well at stabilizing the ankle joint more in the transverse plane than the coronal plane as we previously thought. This suggests that braces that are designed to have more medial to lateral compressive forces to resist transverse plane motion coupled with coronal plane restriction devices would be a better design. And that's what we see in this particular brace. That what they did is they took a fairly standard brace and added a couple of extra features to it. One of them was the BOA closure system, that it actually encapsulates the medial lateral plastic paddles that you're used to seeing to provide coronal plane stability. By adding the BOA closure system, it actually provided medial lateral compressive loads, which actually provided compression across the ankle syndesmosis. That actually allowed for earlier return to activity, as if there was a disruption in the syndesmosis, it allowed for more stabilization in that joint. So when we actually look at the research on ankle rehabilitation, The data shows that most grade 1, 2, or 3 injuries can be successfully managed conservatively. This means that we need to protect the joint stability while also allowing optimal loading coupled with ice, compression, and elevation that we're familiar with. For the most severe cases, a short period of total immobilization is needed to give the structures time to repair, followed by early return to mobility. This is the most desired configuration based on the review of the literature, as seen here. So even grades 1 and 2 injuries are best handled with conservative care with respect to protecting the joint load and providing early mobilization. In fact, one way to think about this is even with a grade 3, once you get that halfway immobilized and provided some stability across that joint so that you have some fibrosing across the joint, you essentially can go backwards in time and consider it a grade 2 or even eventually grade 1. So a lot of that depends on the severity of the grade and the timing of the rehabilitation. If we look at the repair mechanisms, that we can see that the ends of the fibroblast are compromised of collagen elastin fibers, as seen here in red. And the ratio of these fibers are actually determined by a lot of different factors. One of them, of course, is nutritional status, health, even age has a lot to do with it. So if you think about kids have a lot of elastin and not much collagen. So their ratio to elastin is higher to collagen lower, and they can do a lot of crazy things and stretch. Whereas if we as adults try to do that, more than likely we're going to tear, because as we get older, our elastin to collagen ratios flip, and we get more collagen and less elastin. Again, elastin is elastic as the name suggests, and they tend to stretch under loads. The collagens tend to tear more easily. So after injury, fibroblasts are going to send out these collagen fibers. And if there's no protection, the motion that's going to occur across that joint segment is going to repeatedly break down the newly formed fibers. So as these new fibers are being formed, stretched out across there, the joint goes through its range of motion, excessive loads go across these newly formed fibers, which are not very many at this point, and they tend to tear. And then, of course, you start getting into this repair, tear configuration, which leads to chronic pathology. However, left immobilized excessively, you will see that fibrosing occurs as the collagen cross-links with each other. And this cross-linking is going to become more random or not linear with the cellular tension that forms from joint loading. So you have the cross-linking gene in all kinds of different directions with these collagen fibers. And of course, we call that fibrosing or scarring of that injured structure. This, of course, can reduce range of motion and even disrupt neuron routing and function from the ligaments and joint capsule. So that's one thing we have to consider, is that the ligament joint capsules have afferent nerve fibers, and that these provide neuromuscular feedback mechanisms for fine motor control of the joint during movement. It provides us proprioception to know that where our joint is in space, that we can literally close our eyes and move our hand up and down, and we know what position that is. And that comes from the type 1, 2, 3, and 4 nerve endings that are surrounding that joint within the capsule and ligament. So it's widely accepted now that while ligaments and joint capsules do provide some stability across the joint, most of the joint stability comes from the muscles and tendons that transverse the joint and not from the ligaments and joint capsule. The ligaments and joints capsule's primary job is joint proprioception, or neuromuscular feedback. So if you want to stabilize a joint after injury, your primary focus must be on neuromuscular rehabilitation for that joint. So tying this all together gives us a rehabilitation program that provides our patients the greatest opportunity to alter the future course of healing and return to early activity. So instead of the normal rest, ice, compression, elevation that we're used to seeing, the better configuration really should be police, or protect, optimal loading, ice, compression, elevation. Again, you really want to protect that joint for the first 24 to 48 hours. And again, this is when you're going to have that reparative phase where you're seeing fibroblasts being laid down across that joint. So you want to give it time to actually lay those collagen fibers down, provide cross-linkaging so that it has some stability on its own. It can't have any kind of repetitive force and repetitive motion stretching those fibers during that protective phase. After that time, you really want to then start to stretch that joint out and allow for normal motion to occur. So this is going to be primarily with physical therapy, with range of motion exercises, and then eventually strengthening exercises coupled with them. At the same time, though, you want to move from a total contact cast or air cast, removable walking cast type configuration to more of an optimal loading type of brace. And again, this is a type of brace where you want to have that medial-lateral compression loads while providing also coronal stability across the ankle joint. So we still want to always consider that ice compression elevation still has a role. Research has proven this time and time again that it actually decreases inflammation, promotes healing, allows for basically early loading and decrease in healing times. So I'd like to thank you again for being with us today. If you have any questions, I'll be happy to answer them. Otherwise, you can also feel free to email me at roy_lidke@rush.edu or roy.lidke@unitypoint.org. Thanks.
Sorry, everybody, about the technical issue. Very sorry. We are continuing with the webinar. The Q&A session will be at the end of the webinar after the 3 presentations. So we would like to welcome our next speaker, Dr. Yap Yu Zhuan. Dr. Yap is an orthopedic foot and ankle surgeon at Park City and Prince Court Medical Center. Dr. Yap previously was the head of orthopedic department at the Perlis Clinical Research Center at Tuan Gu Folish Hospital. Dr. Yap was a part-time lecturer at University Malaysia. He received the Excellent Service Award by Malaysian Ministry of Health in 2006. Dr. Yap is currently the president of Malaysian Orthopedic Foot and Ankle Society. Let's welcome Dr. Yap.
Good evening. I'm Dr. Yap, and I would like to thank Don Joy for inviting me to give this webinar. It's a bit difficult to give a webinar when you can't see your audience's face and response and reactions, but I'll do my best to convey surgical insights into the syndesmosis. The normal anatomy of a syndesmosis, the fibula is located in the incisural notch. Let's see if I can get the pointer to work. Okay, this notch here, and strong anterior, posterior, and interosseous membranes hold the fibula. This allows dynamic movement during gait, and I think another speaker will tell you the biomechanics of the syndesmosis. The fibula, as I said, has a dynamic relationship with the tibia, and it can move up to 3 millimeters up and externally rotate up to about 5 degrees. Injuries to the syndesmosis are usually the most controversial in ankle injuries, and this can occur with pronation, external rotation, pronation abduction forces. You can also get a mild variant of Masoni fractures with syndesmotic injuries, and some supination external rotation stage 4 type. Clinically, you can see it's usually post an ankle sprain, and you can get bruising all the way up to the mid-calf. When in doubt, always compare. You can see the syndesmosis here versus here. The tibial fibula overlap is different. There's a gap here, whereas there's none here. So, signs to elicit will be tenderness over the syndesmosis, which can be positive in 50%. You can do a compression test where you squeeze the tibia and the fibula at mid-calf level. Here you see a lateral translation test where the ankle moves slightly when you apply pressure, lateral pressure over the calcaneum while you stabilize the fibula. Here's the normal side. You can also do an external rotation of the ankle test with a knee flex, but combination tests are usually more accurate. It's very important to have a high index of suspicion because this syndesmotic injuries accounts for 5% of all ankle sprains. If you can see an ankle sprain where there's extensive bruising and swelling, always look for the syndesmosis. As I said, always compare. Look at the gap here and look at the gap here. Diagnosis is usually made with a few parameters. You can look for the medial clear space, which is usually less than 4 millimeters. The ankle joint space should be symmetrical, medial and lateral, usually about 2 millimeters gap. And then you can measure the talocrural angle, which is the angle you see here, usually around 83 degrees plus minus 4 degrees. And then the talar tilt, which is usually less than 4 degrees. If you look at the tibial fibula clear space, it's usually less than 5 millimeters. And of course, there's the Shenton's, so-called Shenton's line of the ankle, and you must make sure that this is intact. Again, if in doubt, contralateral x-rays. You can always CT both ankles, and over here you can see that posteriorly the syndesmosis is opened up. Now, the diagnosis of this usually can be missed, and intrafluoroscopy is usually done for ankle fractures, where you can detect unpredictable syndesmotic instability in up to 37% of ankles. Again, what you can do intraoperatively, you can do lateral traction on the fibula. You can use either lamina spreader, or you can use a hook and pull the fibula outwards. Check with the image intensifier. Sometimes you may need to explore the medial side if you find that there's still a gap. Intraoperatively, I normally use a fully threaded 3.5 millimeter cortical screw, and the area to insert this screw is usually 2 centimeters above the plafond, up to 3 centimeters. Angle it about 30 degrees from the horizontal. Remember, when you position the patient, what rotation his lower limb is in. Ankle, put it in neutral position. I will talk a little bit about this later. And I normally use a leg screw technique, over drill the fibula, and then with a 3.5 and then 2.5 drill bit over the tibia. I usually do 4 cortices and leave the medial side proud, and sometimes in big patients I use 2 screws. Here you can see why I use 2 screws, because at removal the screw breaks, and here it's easy to take them out from the medial side. Sometimes the diagnosis may not be so clear. Look at this patient with a Weber C-type fracture with open medial clear space. My registrar has done the case with a syndesmotic screw, but there's still a medial clear space opening. Intraoperatively, there was an osteochondral fragment which was trapped in the medial side, and after removing it, then the syndesmosis can be reduced, and here again I put 2 screws. Now, for pure syndesmotic injuries, aka your high ankle sprains, of course, another speaker will talk about the non-operative management. where if it's an incomplete high ankle sprain or an undisplaced stable high ankle sprain, you can treat conservatively. But here, if it's unstable and there's no fracture, I normally do an arthroscopic debridement. Either you can use a screw fixation, or I'll show some newer options. And sometimes you don't even need to use okay, here, this is what you see when I put the scope in, and you can see that the tibiofibular gap, when I stress the ankle, and here even when I do a compression test, you can see it gapping open and closing. And lastly, the last video here, you can see after stabilization of the syndesmosis, there's no more gap. And this is before, and this is after with the screw there. Post-operatively, well, you can remove the screws at 6 weeks minimum. Some people leave it up to 6 months, but it's important to get them weight-bearing after 6 weeks. Newer options include all these syndesmosis fixation like tightrope or zip tight, where theoretically there's faster rehabilitation and no need for removal unless you get infection or knot irritations. So does all these syndesmosis devices provide maintenance of the syndesmosis? Well, studies are now coming up, and there are this was a 2-year follow-up, and you found that it rarely requires removal. It allows for physiological motion of the syndesmosis and an earlier return to weight bearing. I hope you guys are still with me. Another study showed similar clinical functional scores. However, there was a lower secondary procedure rate. You didn't have to remove the syndesmotic device. Again, faster weight bearing time and lower cost. Well, I think you can get lower cost if you consider the cost of a secondary operation to remove the device. So this is an example of a tightrope. This was an orthopedic surgeon who played futsal and had this medial clear space here. And incidentally, his other ankle, that he had a fracture before, but you can see the tibiofibular area is open up. And axial views, you can definitely see the gap in the incisura, and there's also a posterior undisplaced posterior malleolar fragment. With the scope, you can see that the AITFL is torn. However, you don't really need to repair that. Some people have mentioned using a tape device to repair this. And here you can see that the syndesmosis, there's all the interosseous ligaments are all torn there. So with a clamp, you pass the drill through the fibula and the tibia, pull the button over, secure it on the tibia, and then tie the knot on the fibula. Here, this is post-operatively. You can see how the joint space has now been restored. This is another example. This patient actually tackled the ground during football instead of tackling the ball. And you can see that there's extensive bruising and swelling over the end. Here you can see a medial clear space opening. And if you do a full leg x-ray, you can see there's a high fibula fracture, almost a Maisonneuve type. Okay, and here his deltoid ligament was deficient, which needed repair as well. And these are the traits for the syndesmotic device. Here you can see again I used 2, and the joint space has been reconstituted. And of course you need to plate the fibula to get back the length. Now What's controversial about the syndesmosis? Ankle position, for example. Traditionally, it's been said that you need maximal dorsiflexion because if you remember how the talus is trapezoidal shape where it's wider in front and narrower at the back, so you want to make sure that the widest part is in front when you dorsiflex the ankle. But they have done this study by Meta has showed that maximal dorsiflexion is not required. The most important aspect is actually anatomic reduction of the syndesmosis, either through an open technique or an arthroscope technique. So, should the syndesmosis screw be removed? Retained screw fixation does not significantly impair the function. If you remove it, then there is additional cost. So they only recommend it to be removed in symptomatic cases. Paradoxically, another study showed that broken screws had the best outcome. Now, you may ask, why is this so? Well, again, it comes back to anatomical reduction of the syndesmosis. If you don't get anatomical reduction and the screw breaks, then it self-reduces and then you get very good outcomes. So this is another study that showed that 9 patients had evidence of malreduction in the post-operative axial CT scans. After the removal of the screw, 89% of the malreductions automatically reduced. Screw removal also has morbidity. Following removal, you can get wound issues, you can get pain from instability, you can get DVT, you can get a broken screw. So I tend to use syndesmotic devices, and I know of surgeons who do what they say best of both worlds. You put in a screw, you put in a syndesmotic device, and then you remove the screw later on at 6 weeks. Well, I think that's just trying to make money in private practice. So what happens when you get a misdiagnosis or late diagnosis? Here you can see that the bone has actually grown out at the syndesmosis. And you can get chronic instability, either because of inadequate close treatment or poorly performed surgery. With a shortened fibular buttress, you can get a widened mortise and you can get a hypertrophic syndesmotic ossification. And what are your options? Well, if you recognize it early, less than 8 weeks, well, you can do all the techniques which we discussed earlier. You may need to explore the deltoid. If the fibula is malrotated, sometimes you need to do an osteotomy and derotate it. Zwick and Ramel in Dresden, they talk about using a peroneus longus tenodesis with a dynamic 3-point fixation to reconstruct all the syndesmotic ligaments. However, if you look at their technique, it is very difficult, it is very technical, and honestly, I don't think the numbers are large enough to be a gold standard. So other options include salvaging it through an arthrodesis, not an ankle arthrodesis, however, but a tibiofibular arthrodesis. Again, the numbers are not large, only 10 patients, but what they managed to do is prevent them from going to have an ankle arthrodesis. Now, again, with these syndesmotic devices, I think there is a third option. This is a patient of mine, a 28-year-old male staff nurse who's on the heavy side, and he sustained Weber type C fracture, as you can see here with a widened mortise. And here you can see the track of the syndesmotic screw. So this was fixed elsewhere, and the screw was removed at 6 weeks. However, at 1 year, he was still having pain over the ankle, subtle issues where he couldn't do any sports. If you do a comparison x-ray, again, you can see very minimal gap on the normal side, but a bigger gap in the injured side. So a CT scan was done, and you can see again there's a gap in the injured side where there's none on the other side. Axial scans, axial cuts, again you see the incisural gap. So what are the options here? To reconstruct, as I showed you from the Dresden group, to do a fusion like what you showed again. Is there a need for an osteotomy? Well, if you can remember how the x-ray looks like, I think it was reasonably well fixed. So what I did was I did an arthroscopic debridement, clean up part of the cartilage here, clean up the syndesmosis, and then I put two tightrope devices, at the same time remove the plate. Here post-operatively you can still see a little bit of a gap, but he's no longer symptomatic. He's back to playing football, and I hope he doesn't come back with a new ankle injury. Okay, so talking so much about foot and ankle stuff, well, when your passion is foot and ankle, you see things where, they may not exist. Here you see a crane, and what I see is an upside down inverted foot. Thank you for your attention.
Thank you so much, Dr. Yap. As all our attendees here are attending this foot and ankle webinar at 9 p.m., in fact, it's 10 p.m. for our friends in Japan and Korea. I'm sure we all share your passion about foot and ankle. So we are glad to introduce our third speaker, Mr. Cliff Eaton from the UK. Mr. Eaton is a chartered physiotherapist. He spent much of his career working in professional sport at elite level. He had published in internationally recognized journal on sport-specific rehabilitation. So in today's webinar, Mr. Eaton will provide an anecdotal evidences as well as contemporary clinical research on this subject. He has many interesting experience with working with elite athletes. So let's welcome Mr. Eaton.
Well, thank you so much for inviting me to talk with you today. My remit is to discuss the rehabilitation following a syndesmosis injury. So to set the scene, we learned earlier that the mechanism of injury closely relates to that for an ACL injury. So let us start by considering a syndesmosis presentation and our expectations for a positive outcome. DeHue and Peter in 2018, in their systematic review on surgical intervention, stated that a grade 1 can be managed conservatively, whereas a grade 3 will require a surgical intervention. The grey area comes with a diagnosis of grade 2, of which 81% of presentations are graded. The indication for surgery is whether these grade 2 presentations are considered stable or unstable. How this is determined is still open to debate. The term sprain can give the impression of a speedy return to sport, so we need to manage expectation. Verberg et al. 2018 published some evidence-based guidelines stating for grade 1s we can expect recovery in 3 to 4 weeks. Grade 2, 6 to 8 weeks, although longer if surgery is indicated, and grade 3s as 12 to 16 weeks. Now these recovery times can be influenced by the patient's age, fractures, involvement of the deltoid ligament or cartilage damage, and the demands of active daily living. Despite the obvious differences in the structures involved, it has been reported that rehabilitation outcome measures are still generally those used for lateral ankle sprains. So let us consider the components of rehabilitation to maximise the potential for return to sport or activities of daily living and reduce recurrence rates. So Verberg et al.'s 2018 guidelines are immobilisation, for example using an air select walker, moving to functional support such as bracing, exercise for strengthening and proprioception, and manual therapy for range of movement. Williams and Allen, 2018, athletic trainers from the United States, suggested a three-phase approach to our rehabilitation, while some other authors have suggested a four-phase approach. Using the Williams and Allen protocol, our desired outcomes in phase 1 are to immobilise, progress from non-weight bearing to partial weight bearing, address pain, swelling, muscle weakness and range of movement. And what we learned from Roy earlier, that Bleakley et al. In 2011 came up with a new acronym of POLICE. But what do they mean by optimal loading? They describe optimal loading as replacing rest with a balanced and incremental rehabilitation program where early activity encourages early recovery. And this is achieved by promoting mechanical stimuli into the affected tissue to induce cellular response, tissue growth and repair. Interventions could include manual therapy, non-weight bearing, partial weight bearing, progressing to full weight bearing activities, strengthening activities to retain muscle and tendon integrity. Jarvinin et al. Recommended commencing with isometric muscle strengthening exercises after a brief period of immobilization and rest. I have long been an advocate of incorporating neuromuscular electrical stimulation or muscle stim into my rehabilitation. I cannot fathom why we allow muscles and tendons to denature only then to spend time rebuilding them. We can maintain their integrity with muscle stim without putting undue stress on the repairing ligaments and joints. Now, in the early stages of syndesmosis rehab, we need to avoid external rotation of the ankle. Therefore, I suggest utilising the muscle stim within the boot. As symptoms allow, we can gradually progress our loading strategies from isometric through isotonic to isokinetic, and in end stage promote specific functional loading depending on the patient's demands. And I would encourage combining muscle stim throughout the rehabilitation process, as there is an abundance of quality studies to demonstrate its effectiveness compared to just using exercise alone. Progression from phase 1 is proposed when assisted ambulation is no longer required. The desired goals of this phase is to normalise active range of movement, regain good quality movement control and basic function, progress strengthening and proprioception. Not encouraging dorsiflexion can be counterproductive, as the talus does need to be able to move into the syndesmosis for basic function. So mobilisations and mobilisations with movement should be encouraged. As Bruckner and Kahn remind us, the foundation of any successful rehabilitation protocol is ensuring good motor re-education and muscle activation. So before we start thinking of strengthening proprioception and flexibility, we need to ensure quality of movement and addressing any compensatory movement patterns throughout the kinetic chain. This is also the time to consider the functional sporting demands of the patient, so we can build the foundations for our end stage rehabilitation. So work through and challenge the whole kinetic chain and work on biomechanics in a controlled and pain-free environment. Muscle stimulation is again a great adjunct during this stage. We can use it combined with active exercise to increase strength gains by promoting tetanic contractions. demands of the patient. We can also combine it with our balance exercise that increase proprioceptive awareness by providing a low frequency afferent stimulus to the brain. So while we give great consideration to muscles, ligaments, tendons, fascia, nerves, biomechanics, movement control, proprioception, all during our rehab, how much emphasis do we place on the central processor that integrates all of these systems? Now, speaking with Dr. Cheryl Calder, whose testimonials on performance enhancement speak for themselves, she told me to treat the brain like a muscle. If you don't use it, you lose it. The sporting brain especially has to process a lot of information and react very quickly. Allow it to become detrained and we have potential for injury. International injury audits tell us that most injuries in team sports occur in the last 20 minutes of a game. Now, having worked in this industry, I know this will not be fitness related, but could well be due to cognitive fatigue. Why is it that 50% of hamstrings have been shown to reoccur within 1 month returning to competition? That's not training, that's competition. What is it about competition that makes a difference? We have anxiety, stress, consequence, all now have a bearing on performance. And we know that these negative emotions have an adverse effect on movement control, hence increasing the risk of injury. So we need to train the brain. During our rehabilitation exercises, ensure that we dual task, involve both upper and lower limb extremity challenges. Challenge the brain further with visual acuity and cognitive tasks, such as catching a ball while singing a song or solving mathematical questions, all while completing complex movement patterns. We want the brain to learn in the subconscious. You may note in these video clips that the patient's wearing a brace. This particular one is very good as it provides adjustable air cushions that support the recovering syndesmosis while we exercise. Now, some therapists suggest we should not encourage patients to wear a brace as they can become reliant on them and do not enhance proprioception. Actually, the reverse has been shown. Lindley in 2015 showed us that bracing not only provides physical and psychological support, especially relevant for patients with kinesiophobia, but also provides an afferent stimulus to the brain. Using fMRIs, they have shown that providing such a stimulus results in both the sensory and motor cortexes lighting up at the same time. So the afferent stimulus can lead to enhanced movement control. Look at these objective findings taken from the Chattanooga Huber 360 platform, showing lower limb stability with and without wearing a brace. Piaget's theory of child development also supports this concept of sensory input promoting movement control. Earlier, I mentioned the use of a low-frequency muscle stimulation to provide a sensory input to the brain. Look at the enhanced proprioceptive awareness of this patient once the muscle stimulation is activated. Progression to phase 3 of our rehabilitation is determined by the ability to jog and hop with minimal discomfort. Now we want to progress those specific sporting or work-related demands that we identified in phase 1 into controlled and uncontrolled movements. For sports, having an understanding of specific demands is key. In a paper I published back in 2006, I identified the high and low intensity activities with associated work to rest times for different playing positions in rugby union. This allowed me then to mimic these demands using the SAID principle, specific adaptation to imposed demands. Starting in a controlled way and progressing to a more uncontrolled situations, all of the time ensuring that I was continually providing cognitive challenges during the exercises, hence encouraging the brain to learn correct movement patterns in the subconscious. Another consideration during this phase is rate of load. Peter Malliaris points to studies that show exercises that may provide the same force to body weight ratio, for example a squat and a counter jump, but will produce huge variances when it comes to rate of load, that's body weight per second. Also in 2006, I published a second paper considering how we could bring all of this together, combining sport-specific demands with cognitive load while physically and mentally fatigued. The STAR drill can have as many legs as you require. The patient always starts and returns to the centre and must complete the given task in the correct order, e.g. 1, 2, 3, 4. The work to rest times can be adjusted depending on the sport demands or playing positions, and mistakes should result in consequence. So to bring this all together, we need to think a lot more about including visual and cognitive challenges to enhance our rehabilitation outcomes. We need to train the brain, and we can use adjuncts such as muscle stim and bracing to facilitate this. And for those of you thinking, Cliff, it's a very privileged position with all those facilities you had available to you, let me show you this example of providing a lower limb rotational challenge combined with a cognitive challenge in a private practice. Now this is an ACL reconstruction patient, but at the offset we've been asked to consider a syndesmosis rehab like we would for ACL, so I make no apologies for this.
Incorporate automatic pilot. So what I'm going to get Nick to do is to do a step routine that he knows. I like this one because it involves turning. It's an important skill to have to protect your ACL, to be good at turning. And stop, but we're going to make it more tricky for him by asking him to sing while he does it. Off you go, Nick.
Today's gonna be the day I'm gonna throw it back to you. Right out, should have somehow realised what you got to do.
And stop, that's lovely. Now, this is really tricky. On every 8th step, he's got to sing, but also count, because on every 8th step, he's going to change direction. Here we go.
Today's gonna be the day I'm gonna throw it back to you. Right out, should have somehow realised what you got to do. I don't believe anybody feels the way I do about you now. Okay, well I hope that's given you some ideas about how you can enhance your rehabilitation outcomes. So that simply leaves me to thank you so much for your valuable time and attention today, and along with the rest of the panel I would be happy to take your questions.
Thank you so much to Mr. Eaton's such interesting presentation. Following his presentation, we are going to show you a 2-minute video of the rehabilitation exercise that he just showed in his presentation. After this 2-minute video, the Q&A session will start. So please stay on with us during the Q&A. We have many interesting questions.
Ankle sprains are a very common injury, and rehabilitation of the peroneal muscles is important in reducing the risk of recurrent injury. Using the wireless professional is a fantastic adjunct in this process. The peroneal muscles can be exercised early in the rehabilitation process without any constraints placed on the affected ankle joint. Muscle work can be started in non-weight bearing, and if desired, eccentric work on the perineals, everters, can be induced by actively recruiting the foot's inverters. Reduced balance is a common finding post-ankle trauma. By combining the wireless professional with traditional corrective exercises, the outcomes can be greatly enhanced. The increased proprioceptive awareness very quickly allows even more challenging balance demands to be achieved.
Okay, thank you all. Thank you to all three wonderful speakers. Now is our Q&A. So the first question, clinicians all understand the importance of rehab for ankle sprain. But after the initial treatment, sometimes they have no more symptom. So for example, when they are off the walker, they are already walking normal, no pain, no felt instability, they don't come back to rehab. So what is your experience to try to convince your patient to come back for rehab? Dr. Yap, do you experience such challenge?
Okay, the question is when the patient feels well, how do I persuade my patients to come back for rehab? Am I right in your question? Is that the question that you're asking? Okay,
Yes.
it's very simple. After an ankle sprain, be it a subtle high ankle sprain where there is no obvious anatomical evidence of widening of the syndesmosis, that means your simple type 1, type 2 sprains and all that, which are not going to be treated surgically but conservatively. When they come back for follow-ups, I usually get them to do a single leg balance test. So if they can balance on the injured leg as long as the other side, which is normal, with their eyes open and with their eyes closed, then I would probably say you probably do not need much physical therapy. You can start to go back to a little bit more sports, like starting off with a little bit of cycling, swimming, non-impact exercises, followed by light jogging, treadmill, and then from then on going into active sports, of course with a gradual onset, right? So if they can't do the balancing and it's not as good even with their eyes open, then they definitely need to go for physical therapy and rehabilitation.
Great, thank you very much for the great suggestion. And Professor Lipke, what's your suggestion for that?
Yeah, I usually try to explain how neuromuscular rehabilitation takes a little bit longer than the typical muscular and mechanical rehabilitation. So I really try to make the emphasis point for that patient.
Great. So Mr. Eaton, you treat athletic patients. Are they more compliant to rehab or not?
Yeah, I mean that's a privileged population, and yeah, they definitely definitely are more compliant. But I'm so glad this question came up, because I feel very passionate about this, and I actually ran some courses for doctors in the UK, because certainly in the UK. When a child goes over on their ankle and the parents take them to the doctor, they're told, "Oh, it's just an ankle sprain," you know, and that's to alleviate sort of, you know, the parent fears and the child's fears. Okay, but once you start talking about just a sprain, that's taken over then into later life. Now, I've worked with top level coaches who have then said to me, "Oh, he's just sprained his ankle." No, okay. What I really feel strongly, this needs to come from the doctors, where the doctors tell the patient that they have torn, or indeed in some cases ruptured, the ligaments in their ankle, because this is a much better description of what's actually happened, and really relays the trauma involved, and then go on to say that you've torn or ruptured these ligaments. It's going to take a while for them to heal. Now, your symptoms may well settle down in the meantime, but in order that you don't have long-term issues, you must be compliant with your rehabilitation program.
Great input. So that actually leads to the second question. As all of you mentioned, that syndesmotic injury are often misdiagnosed, or a patient first thought that was a simple ankle sprain and it didn't heal after 4 to 6 weeks, and then they came back and it was diagnosed. And by then, the condition may become there's chronic symptoms. So how could we manage that? Maybe starting with Dr. Yao again.
Okay, that question, I get that from my patients all the time, because as an Asian population, I'm sure most patients, as what Cliff has said, they think it's just an ankle sprain. So they rest, they've sprained their ankle before. Sometimes it's a little bit more swelling, a little bit more bruising, sometimes it's less, and then they just ice it, they rest it, but it never goes back to normal. So when it does not get back to normal, that's when they come to see us, okay? And if it comes in the face of an acute injury, then the whole rise of police thing starts again, and then they go for therapy. And I don't have a fixed regime on when to send them for therapy. Generally, it depends on how the patient is responding to the healing process. If they come in crutches, they are not even able to put weight on the ankle, but it's just an ankle sprain, you know, there's no evidence of disruption of the syndesmosis from x-rays. The MRI shows that it can be treated conservatively. Then I generally get them to rest a week to 2 weeks, or maybe even up to 3 weeks. And then they come in again, and that's when I reassess them whether they need to go for therapy at that point. Now, if they have already sort of done their own therapy, or they get referred to me by the therapist, and that's usually a different ball game. As you know, probably ankle sprains are the most common sporting injury, and 80% of ankle sprains will heal with conservative therapy, even though, you know, an MRI may show that it's a torn ATFL, for instance. So when they come in, even though it's subacute or a little bit more chronic, if they haven't been to the therapist, I send them to the therapist. If they are hard up for time, they want to know and get a quick fix, then they get all the investigations. They get x-rays, standing x-rays, weight-bearing x-rays. If your facility has a weight-bearing CT, you can do that. They get an MRI to see how badly the ligaments are injured, whether there's any residual fluid in the incisura that tells me it's a chronic ankle syndesmotic instability. So those are cases where surgical intervention would be better in the beginning before you need physical therapy. So if they are the type where say, okay, no surgery for me, therapy. So off they go to the therapist, at least 6 weeks to 3 months of intensive therapy, proper therapy. What I mean by that is not like once a week physical therapy, but at least 2 to 3 times a week. And after that, they come back. If they continue to improve and they can do whatever they want to do, whatever sports, then I just let them continue on with that. If at any point in the rehabilitation process, they have difficulty, they get more pain, they don't rehabilitate as well, and you know that eventually they need surgery, then I try to intervene early. And usually I work with my therapist in that sense. They will feedback to me that this patient is not progressing in the rehab. So those are ones that, you know, I usually counsel for surgery. Surgery is always the last resort.
Yeah, thank you. And Professor Leakey, how would you approach the chronic symptoms?
Yeah, I would first say that we should probably never ever let it get to that point.
Yeah.
You know, we should really start treating it right away correctly the first time. The problem is when you get to that chronic situation, it's extremely difficult, you know, and you have to explain that to the patients that, okay, we didn't do the right path the first time, or you didn't anyway. But now we're going to go down this path that's going to be much more difficult. This could be a lot of physical therapy. Like we described before, you've got the fibrosing. It's going to take quite a bit more painful therapy too, to try to get those fibers realigned and get back to normal. And then after that, it's going to be even longer for that neuromuscular rehabilitation, trying to get them back to the level of sport or level of activity that they want to be at.
We're getting late, so the last question actually came from, for you, Cliff, your presentation. We learned about, it's important about the motor learning, neuromuscular training. How long does the neuromuscular training effect happen, or the carryover learning effect could take place? And can we optimize
Great
it?
question, yeah. Now, when it comes to neuromuscular relearning, that is very dependent on the athletic ability of your patient. So if you've got a patient who's been used to athletic training, quick movement patterns, fast reactions, they're going to recover the plasticity of their neuromuscular pathways much quicker than somebody who's more of a couch potato or an office worker. So that is one consideration that you're going to have. The other consideration is what type of operative procedure there's been, as Dr. Yeep has correctly said, that the rehab's going to be different if we use a screw or if we use wiring. So that's another consideration. But the earlier that we can introduce things like muscle stim onto the muscle to reduce the effects of losing the plasticity of the neuromuscular pathway, the better. So what we do here in the UK, and certainly the ankle surgeons I work with, is as soon as the dressings allow, we're going to put muscle stim on the muscles. And even if we're not getting a tetanic contraction, we're using a low frequency, so we don't get tetanic contraction of the muscle. We might just be improving blood flow to the area, which is obviously going to enhance the healing process. But because of that afferent stimulation to the brain, it's really going to sort of help along our rehab. So long answer to a short question, start as soon as possible.
Right. Oh, Dr. Yip, yeah, you have question for Cliff?
No, I just like to add on to what he said. All my patients post-operatively start physio the very next day, the first post-operative day. Okay, so that I think is very important to ensure very faster rehabilitation.
Thank you. And Professor Leakey, I remember you published a paper about foot orthosis, reducing patient knee pain, and that neuromuscular training effect continued even when they don't use the orthosis anymore. So would you like to add more comment regarding when the neuromuscular training effect could happen and how to optimize it, maybe through devices?
Yep. Yeah, and I agree with what everything that Cliff said too, that I just gave this lecture on neuromuscular adaptation, and we demonstrated that even after you stop wearing any bracing and support, and you do any kind of gait analysis testing for them, that effect stays there. For the most part, we've seen it occurs in about 1 month is when you start to see it, where you can take it away after a month and it's still there. Usually between 1 month and 3 months, depending on the patients, of course, like Cliff said. But for the most part, you pretty much assume that it's going to last for almost the same amount of time that they've worn it. So if they wore it for 3 months, you pretty much assume it's going to last for 3 more months afterwards. So that's what our research has found anyway.
Okay, that's great. So I would like to close this webinar and thank you everybody so much for staying with us despite all the IT issues that we had. So at the end of the webinar, you will get a survey link. So please accept this survey link to help us to improve. And the replay of this webinar video, or the video, will be available by next Monday on DJO social media, including the Facebook. So if you miss some part of the video because of the technical issue, or if your colleagues and fellow co-workers that want to see this video, you can watch that from next Monday, and it will be available for 2 weeks. So thank you so much for all our speakers, and thank you for joining our webinar, and hope to see you again in the future webinars. Thank you. Thank you.
Okay. Thank you.
Thank you.